Yes, people, what's going on? Right, I promised that I was going to do this live Q&A, and now I actually can do it. I feel like I'm organised enough to do it, which is good. And I know that people have been putting in their questions on my story, and I've got loads. So we're going to hopefully get through some. And I'm trying to be really savvy here by doing this on Instagram and on YouTube. At the moment on YouTube, I've got the grand total of no one watching me, but never mind. Hopefully, I don't know if you can see my dog messing around there. Anyway, hopefully this will be useful. So yeah, we've got loads of Q&As, and we've got some. I always get some every time I do a Q&A. I guarantee you, I get some ropey questions. But I'm going to go through some of the good ones, really. So hopefully you find it useful. But I've not gone through like the questions. I've not like chosen any yet. So I'm just going to choose. Oh, look at this. This is a good one. Let's pick this one to start with. So what do you suggest instead of clamshells? Since you've mentioned it can be irritating. Now, I think I have to, let me make this clear, right? No exercise is bad, right? If you compare people just not doing any exercise at all, nothing's bad. But I'm talking about the context of someone who's got hip pain, right? So whether you've got an intra-articular problem, hip flexor, labrum, FAI, dysplasia, those kind of things in and around the hips, they can be quite painful, right? They can be quite irritating. And the difficulty is there are so many things that could be better. There are so many things that you could do that potentially, realistically, could be a better choice, because the way that the clamshell is, let's say you're sideline, right? Textbook clamshell, sideline fetus position, doing external rotation. That iliopsoas snapping over the front of the hip and that compressive load can sometimes be too irritable. It can often provoke it. And if you even think about the situation of someone completely different, right? Someone who has glute tendinopathy, right? So someone who's got GTPS, and you're giving them a side-lying external rotation exercise with the hip flex, essentially is probably going to provoke their symptoms more, because it's not doing what people think it does, which is, does it do the glute med? It doesn't. There's loads of other things. And when your hip is flexed more, the more your hip is flexed, the less of an external rotator your glute med is anyway. So giving them something like that, it doesn't really quite fit. It doesn't really quite make sense. And there's better exercises that you can do. I just like doing exercises in standing, makes people feel a little bit more confident. But look, if you come into my clinic and you tell me, Mehmet, I'm doing 500 clamshells a day and it doesn't hurt and it's the only thing that helps, fill your boots. I'm not going to stop you from doing it, but I just think there are better exercises. But I'm not like against it. And so, by the way, just FYI, YouTube is kicking off. A minute ago, I had one person watching this. Massive. I'm big time. I am big time. Right, let's see what else there is. Let's have a quick look. So we have a couple of questions that are fairly similar. Okay, so this is a pretty good one. I like this. This is a bit different. So any tips you apply when navigating diagnostic uncertainty with patients? This is great. I'm going to give this from the perspective of the physio and also from the perspective for the patient as well, right? So diagnostic uncertainty is essentially the life of someone who specializes in hips. And to be honest, like most physios will understand this. It is so common to be able to manage someone, treat someone, improve someone, and resolve all their symptoms without you even knowing specifically a isolated cause of their symptoms in regards to like putting a label on it, because there's so much that you need to do. There is so much due diligence that you would need to put in as an imaging workup, a diagnostic workup, to be able to confidently really say this is your diagnosis. You don't need that to start rehabbing someone. You don't need that to start treating somebody as a person with your physio. But the difficulty is twofold. The difficulty is some patients don't like it. Some patients do want to know an answer. Some patients want a label. Some patients just want to know that you know what you're doing. Other patients aren't that fussed. You know, no one comes into your clinic room and says, Like, I tell you what, to date, no one's done this anyway. No one's come into my clinic room and gone, Mehmet, you know what? I need your help. My adductor longus is just weak. I can't live with it anymore. My adductor longus is just too weak. No one says that. No, everyone just comes in and is like, my hip hurts. I'm in pain. Make my hip not hurt. So some people don't want or necessarily need that label, and you certainly don't think you need it to get started with. However, if someone sent me a request, as if I'm going to let some randomer give you, I'm not going to give like some randomer the controls to my live stream. Are you mad? I've only just about managed to figure out how to do it myself. No one in their right minds is going to like decline the physio or the rehab. However, like there comes a point in time where if you're doing all the things with good clinical reasoning, and that is paramount, like you can't just wing it and do nothing like random stuff. You've got good clinical reasoning and your symptoms, the patient's symptoms aren't improving within the time frame that you set, then you've got to ask the question, why hasn't it got better? What do we need to do to identify it? And do we need to start switching our hypothesis into a diagnosis? And from that point, then that's when you start doing the things around scans and injections. I've literally just done a YouTube video now on MRIs when they come back normal. And what was the other thing that I did? And my God, my memory's so bad. I literally just done it. Hold on, I'll tell you. And the other one was, that's it. Can exercise fix a labral tear? I don't think that's that relevant to that point. But anyway, the bit I meant was about the MRI, because sometimes people go for imaging, it doesn't tell you what you necessarily want to hear, or there's a few things that are going on. Loads of hip pain can be a mixture of instability, of hip impingement, morphological makeups, loads of factors. However, also, pain is quite complicated. It's never as straightforward as just, my labrum is torn, please can you fix it? Good question though. Whoever said that question, top of the class. I'm a big fan of that so much. Big fan of that so much. These are good questions. Look at this. I don't know who's asked these questions because it's not showing me, but like take full credit if this is you. What is your narrative / take on how you work as a physio? I like this. Fairly deep, isn't it? Fairly deep. So my take on it is, look, and hopefully any of my patients watching this will vouch for me, because if they don't, then I'm opening myself for a whole heap of abuse. But I'm really passionate at just treating people as people. I try to kind of leave that. It doesn't sit well with me when I kind of have seen clinicians work and you really can tell there is this divide and barrier between physio and clinician. And I don't like all of that stuff. Sometimes, and I don't mean like be unprofessional, and I don't mean don't do the formalities and all of that stuff, but I think you have to communicate well. Everything that I do, and something that I'm so passionate about when I teach, when I'm with my patients, and just generally, is that communication is so key, like to everything that we do. And this is one of the things that we do on the mentorship, is I talk like one whole week is just around communication, because like clinical tests, they're all rubbish. Like the clinical tests are rubbish, tests are rubbish, this is rubbish. Like it doesn't mean that you can't get good outcomes for patients, but it's all about just trying to communicate. If you can communicate well, you're already winning. Look, guys, let me tell you this, right? I'd say some of the things one of the top things that I would prioritize above and beyond anything else that I would put my focus on before I've done anything else with a patient is rapport. Rapport is key. Rapport, you've got to think, right? Rapport is 80-90% non-verbal. That's how powerful communication is. Now, I don't mean like just walk into the waiting room and just go up to a patient. Just don't just stare at them, like, because that's weird, right? But like communication is body language, the way you talk, how you are, how you approach them, and like all of these things are key. If you can build rapport that quickly and that effectively, that little bit of diagnostic uncertainty that you've got a little bit of leeway to help with that patient still. So I think anyone that's watching, the 3 people on YouTube that are watching it, when's my subscriber thing coming through? The 3 people on YouTube that are watching, you lot anyway, I think the key thing is, if you're a physio and you're new and you're junior, just learn and thrive and really develop your communication skills, because I think that is key. It's really funny. Someone just put a question in the question box saying, how do I ask a question? I think you figured that one out, my friend, already. Let's have a quick look. What else have we got? What else can we have? Let's have a look. God, some of these questions are a little bit too in depth. Right, let's have a look at this one. So, gluteal tendinopathy. I'm having physio, but I'm never not in pain. How long will it take? Imagine it. Just imagine how rich I would be if I could just sit here and go 3.5 months. November the 14th, gone. Just all your pain gone. November the 14th, not too long. I don't know. Like it takes time. Like gluteal tendinopathy, when you're kind of embodying it within that GTPS type umbrella, is slow and stubborn, and that's if you don't have any of the coexisting comorbidities. So and what I mean by that is smoking and drinking, or autoimmune issues, or inflammatory conditions, stuff like that. If you don't have any of those things at play, it takes a while. Like you've got 12 to 16, 18 months, 2 years almost, the natural history of GTPS can take to settle down. So the important thing here is this. You got to control what you can control, right? And what you can control is the kind of input that you're receiving, the kind of physio that you're getting given, and your adherence to that plan. But then as a physio, your job is to make that easy for the patient. Your job is to try and make that patient want to do it. Your exercises, the exercises that you give, they're not going to be adherent to it if you're giving them 100 exercises on the sheet and not treating them specifically as an individual. But there will be if you kind of listen to them, figure out what their kind of goals and aspirations are, and gradually do it. So as a patient, when you're asking how long will it take? It will resolve, everything ultimately at some point will resolve. But my advice will be, don't just focus on the here and now. Get the short wins, focus on the things that you can focus on, and be really good. Someone just actually asked, Sagar, my old work buddy, Clams, mate, if you actually signed on to the live stream and watched it when I signed on, you would have heard that was the first question. Get out my live stream. You're off. You're sacked. Get out. I'm joking. I hope you're all good, Sagar. You handsome man. So, let's have a look. So someone has said, had total hip replacement at the NHS. When should formal physio be started? Is the app ready? That's enough. I'll come back to that, because this is more about me doing a live stream. For those of you that are wondering, the YouTube is kicking off. I've got 4 people watching now. I don't know. What can I say? Right. So the thing is, NHS total hip replacements, ultimately, the majority of the time, you're not going to get physio, because there's a lot of evidence that demonstrates for the general population who have a hip replacement, you cannot do physio and you will do okay. But that is not for those people wanting to get back to exercise at a decent level, not the younger demographic, not the ones wanting to do more. A lot of that is based on the common demographic of someone who has severe hip arthritis that has a hip replacement, which is arguably 65 years and plus. So if you start taking decades away from that, right? And even if you're in that age, I'm so passionate that people need physio. It winds me up when people have a hip replacement. You're having your hip replaced. Which bit of that makes sense that you shouldn't have physio? I don't get it. In what capacity does someone have a hip replacement and someone somewhere has thought, I think they'll be all right not having any input after they come out of hospital? You need the input, because patients get worried. Look, my next video that I'm going to film, because my memory is bad, is specifically for this. And it's around, what have I titled it? Oh, it's not even that one. Never mind. But it's essentially around what patients need to understand and be aware of post-operatively, because there are so many things that patients don't. Yeah, you walk up and down the stairs when you're in hospital, when you go home, but you don't really understand, how can I sleep? How can I not sleep? When do I stop doing the precautions? Precautions also, talk about old, right? But precautions, when to and when to not do them. All of these things are so important, but you can do these in a physio appointment. Even if it's an online consultation, 1 or 2 sessions, your outcomes are going to be so much better, so much quicker, versus if you don't have anything. So my answer to you, because you have asked me a question, I've actually not answered you, but you've said, when should formal physio begin? For my patients on my caseload, if I'm seeing them first post-op and they're my patients, I want to talk to you like 7-10 days in. I'm not going to be getting you doing lunges, lifts and squats on day 7, but I'm sure as hell going to spend a lot of time educating you, reassuring you, telling you how to walk properly, when to come off your crutches, how to use stairs, when to not do your precautions, how to sit on the toilet and wipe your bum. All of these things are just life. And it's hard to navigate that on your own if you've got no one helping you. Oh my God, I'm talking quick. What we got? I'll do another 9 minutes. I don't want to bore you. No one's going to sit back and watch this for an hour. Let me do it for half an hour. So I won't use this as a question, but someone's put, it's a nice area. I'd like to specialize in it too. So I would agree. I think it is vital, I'd say, if you're going to specialize it, you specialize in hips, because it's the most exciting joint. Come on, guys, back me up. You know, it's the most exciting joint. Okay, this is interesting. Let's bring this up. This is a bit like not the clearest question, but I'll clarify. So it says, how can you tell the difference between pain caused by an unstable hip versus a labrum tear? Right. So essentially, this is the difficulty here. Oh, actually, hang on a sec. Someone's also asked me about alignment. Remind me of this in a second, because that's a good question I want to answer. Actually, I'm going to put it here. I'm going to write it down. Remember pen and paper? Right, I'm going to put that down here, because alignment is the other thing I want to kind of like discuss. Now, how can you tell the difference between someone who has hip pain caused by instability or a labral tear? Now, the question, the thing is, right, if your hip is painful, the first thing that you've got to ask yourself is, what is it that's causing your pain? Now, if you've got someone who's got hip instability and you're kind of thinking it seems like the hip joint, and they're not an arthritic hip, or they don't have something of that nature, the thing that's often driving all of those symptoms is the labrum, right? But the labral tear that someone might develop or that might be experiencing is not the cause. The labral tear for sure is the site of pain, is the thing that's causing their grief, is the outcome of something. But if they've not had some sort of trauma, or they've gone skiing and they've done the one of them situations, or their legs being pulled off or whatever, if they haven't had some sort of trauma, but they've got a labral tear, then the question is, what's led that? So the labral tear is the effect. I want to know the cause. Is it FAI syndrome? Is it hip dysplasia? Is it micro instability? Or is it a subtle borderline dysplastic hip that has an instability component to it? Those are the causes. The labral tears are essentially the effect and the outcome from that. So the question at that point now, for both the physio, the clinician, the surgeon, the patient who is presenting with pain, is trying to understand two things. It's trying to understand, where is the pain coming from? And that's why you have things like diagnostic injections, right? When you have a diagnostic injection, if you've got labral tear, you go and have a diagnostic injection. Yeah, it might get rid of your pain. It might tell you that your pain is coming from the labral tear. It doesn't tell you why it's torn, right? And that's why it's really important, and partly why it's so much of an issue that hip dysplasia as a driving force to that and as a risk factor for arthritis often gets missed. And also why hip impingement is important to pick up, because that is a risk factor of hip arthritis. And also both of those things can contribute to someone having a labral tear. As a clinician, trying to diagnose someone's hip instability clinically is challenging. Like I said, the first thing I think I said, hello, everyone, clinical tests are crap when I started this live stream, but they are. Clinical tests have huge limitations to it. And it doesn't take you long to go and find a systematic review, meta-analysis of clinical tests for hip joint instability, and you will see the limitations that we have. But that's why the chat is so important. Subjectively, you will get so much of an abundance of information to help you understand whether or not you think someone has an instability component or not, whether they have an hip impingement component or not. And then understanding those pathologies, the common demographics, who they are and who they're not. And if you're not sure, all you've got to do is cover my course and I will teach you all of this stuff. Imagine the laughs. Imagine the time that you can have coming on a course, listening to me do this for 2 days on your weekend. 2 days, just me chatting about hips. Probably not a way to sell a place with my course, but anyway, alignment. this is someone put something about alignment. And I was like, that's the thing. You know what annoys me? I'm going to now, this is my own little thing, because I know this is a Q&A, but this is just my A without the Q, right? There is so, like, why do people put content out on different platforms and stress so much about alignment? Patients struggle with that kind of stuff. You know, there is, I think from my perspective, being almost at the cold face front of like people who have persistent hip pain, people don't have persistent hip pain because they haven't had something realigned yet, or because something has been out of position or something has slipped. Like, that's not the case. Like, these are very, very simple things that patients get told as a result of them having persistent hip pain. And it's not helpful, because patients then go away thinking, they get worried. Like, imagine someone says to you, or like, your leg length is a bit off, or your pelvis is shifted. That sticks with you. It's negative. Like, I'm not saying just be like wishy-washy with your patients, but patients will remember that stuff. And then they kind of think it's my fault, like as in not my fault, as in they think as a patient it's their fault because of their anatomy or their fat. And that's not the case. Now, I'm not saying when you're doing exercises, we let them do it if they're absolutely butchering the exercise. But I don't know if there's that much value being so hyper analytical and so to the point of where someone's doing a squat and you're like telling them, your knees dropping in too much, or like, make sure your foot doesn't twist a little bit. Like, just let them do the exercise. Let them do it. Let them feel confident doing it. Support them for sure. If they're absolutely rubbish at doing them, give them another exercise. But I think this hyper analysis of like biomechanical perfection is never that conducive to someone having a successful outcome from their recovery. And I think sometimes it actually makes things probably worse, because they start to get a little bit more concerned by it. This is a nice little question. We'll do one or two more questions and then we'll call it a day, because we've all got things to do, guys. We've all got things to do. So we should go there. So mild OA, if body reacts well to, if body reacts well to the rehab, could you avoid having a hip replacement? Good question, right? Let's discuss this, right? So look, first and foremost, hip health is on this spectrum, right? Hip health has a spectrum. Here, you've got like nothing at all. I'm talking about young, healthy hip. And here, you've got severe arthritis. Like, old Johnny here is like, endgame. Your hip's knackered. You need a hip replacement. And along this whole line, you've got this spectrum of severe to moderate to mild to the precursors of OA to the risk factors of OA as well. That doesn't mean everyone along that spectrum who gets told that they have some form of arthritis needs to have a hip replacement. Far, far from it. Now, if you're on that early stage where like this person has asked, I have mild OA, for sure, like the last thing that you should be worried about is jumping to have a hip replacement, because often you've got to think as well, like arthritis is not just what you see on an x-ray. It's linked up to the clinical signs and symptoms that someone has as well. So if on paper you've got mild or even moderate, mild OA or even moderate, but clinically you've got good range of movement, your pain feels okay, it's not debilitating you, your quality of life isn't impaired that significantly, and you're kind of doing stuff that you want to do but slightly limited, rehab is your first point. Rehab, good diet, good lifestyle, good activity. That is your fundamental starting point with this stuff. Where it starts to be a little bit more of a different conversation is if you're maybe having moderate, let's say you've got moderate OA, right? Where your pain levels are still up and down, still manageable, but you've got some more loss of range of movement. And as a result, that loss of range of movement is starting to impact your day-to-day stuff. You know, like the textbook, like shoes and socks, toenails, washing feet, in and out of a car, like textbook hip joint signs are starting to slowly creep into that person's life. That rehab for sure can make them physically a little bit more resilient, and by proxy, by doing that, you make someone psychologically a little bit more resilient, right? But the thing that it won't do is it's not going to loosen the hip up. Unfortunately, you know, arthritis is arthritis. I'm an optimal. I'm a not optimist. Yeah, I'm a eternal optimist, right, with all of my patients. But also, you've got to be realistic. Like arthritis is arthritis. If you've got that and then you have a loss of range of movement, a stiffness, a lack of range because of the morphological skeletal changes, it doesn't matter how many times you're going to stretch it and do mobility. Like it's not going to change ultimately. But your pain levels can get more tolerable and physically you can become a little bit more adept at doing stuff. So for sure, like you can negate the need to have a hip replacement. I don't know for what period of time or for how long, or even forever. I think a lot of that comes down contextually to the individual, what they want to get out of it, how active they are, and all of those things really. So hope you enjoyed it. We're going to do more of this stuff because like you saw, if anyone saw from one of my posts a couple of months back or last month, the hip physio is now my job. So split between being in Exeter, in London and online, and doing my teaching and doing all this filming. I'm here for all the time, basically, is what I'm trying to say. So we'll do more of these and some more live Q&A feedbacks. So I hope you've enjoyed it. And if you've had comment, and if you haven't, don't. Thanks. Have a nice day.